for. So let me go ahead and share screen. Alrighty, are you able to see that okay? All right, I'll turn things to you then, Maya. Thank you.
Okay, so this case isn't super interesting. I just didn't come across a lot of like psychiatric cases that I could do something to, but this one we did fax the doctor about this. So basically the patient is 67-year-old male. So he's in criteria where C5, they shouldn't be on benzodiazepine anymore. He has no history of smoking, no alcohol or illicit drug use. Was too low. I know it's not a psychiatric thing, but he's falling, so that's why I was hoping that maybe the benzodiazepine should be taken off of there and change to something else, since he's at a greater. And so now every labs are all local there for that. $5 milligrams to either citalopram.
Maya, I'm so sorry. It sounds like there's some connection issues. You're kind of cutting in and out there. Are you able to hear us okay?
I don't know if it'll kick me off into like my hotspot. I'm on the rotation site's Wi-Fi right now, and we are rural, so that could be a problem.
Okay.
I don't know if it'll kick me off though. Do you want me to try to switch it?
Why don't we try, if you turn off your video, sometimes that helps with the audio. So why don't we try that first, and then let me see. Oh, it looks like she may have actually dropped the call here. Let's see. Oh, I still see you. Yeah, sometimes if you turn off your video, it might help with audio as well. Do you want to try that maybe?
I can't. I switched it to my personal hotspot. Does that seem to be helping?
Yes, that seems to be better. I got a thumbs up from Dr. Swagger as well. So
Okay, sorry. Where do you want me to start?
no worries at all. Let's see. So we were kind of in and out on I guess when you were talking about the medications and getting into the labs.
Okay. So basically he's been taking Xanax 0.5 milligrams. It's been effective for him. He doesn't have any, he said his anxiety is controlled. But because of the Beers criteria and his recent fall, I was hoping we could change his medication, which is my main question, is like, what should we change it to? And how basically do I get the doctor to listen to me or consider my recommendation? He does have other comorbidities such as anxiety, cardiovascular disease. He has stents in his heart. He has like 6 of them is what he said. So I wanted to make sure I put that as like the heart event. He's got a bunch of stents there. He has chest pain with arthritis, diabetes, and some fluid retention, all of the things he takes medications for, and they're all controlled. His A1C is 9.7, which is the only thing that's off for him. So after they took him off some of those diabetes medications, some of them, everything's still controlled except his A1C is still high. So I don't know if you want me to list out exactly what he takes and when, but I mean, you can see that there. He's got a list of medications and everything's under control though, otherwise, besides, I mean, everything's under control, even with the alprazolam. But basically, that is my question is, since it's working and it's been effective, he doesn't have any problems so far, is that something that I should push the doctor to do, possibly is switch it to something else? And what should I switch it to? And possibly how do I get them to listen to it? Because whenever I sent them a fax, they have told the rotation site that I'm at that they throw those away. They don't look at them. So I just, I don't know what to do for the patient.
Thank you so much, Maya. First and foremost, big shout out to you for your first echo case. You did a great job. And Despite connection issues, you were able to come through loud and clear to us. So we appreciate you working with us on the tech there. But yeah, big shout out to you. Thank you. Before the recommendations from the group, did anyone have any clarifying questions about the case? Dr. Swagger, I see you unmuted there.
Yeah, I mean, a great case and a really common thing. I'm sure that that happens a lot. It is simple and complex at the same time. I think my questions are, have you spoken to the patient, and do we know more of the kind of history regarding around how long we've been on the Xanax? I mean, that is a rather non-traditional medication anyway, but sometimes reflects things that happened decades ago and people have just kind of gotten used to it and it works. Has there been any other medication attempts? Do we know the nature of the anxiety? Was it like a generalized worry? Was it more of a panic type? It looks like he's taking it every single day. Do we just have some more of that psychiatric end of the history?
So because I am at a community pharmacy, I don't have the reason why when I filled out the labs, I didn't have much to say. Like I saw on other students where they like gave the PHQ scores and stuff like that, which I just don't have access to that information. I do know that he's been filling it here for years. So you can say he's been on it probably for, I don't know if it's a decade, but he's been on it for a while. He was the most compliant person I have talked to since I've been here. So he definitely takes it every single day. He has also lost a lot of weight recently, is something that he mentioned too. I don't know if that was kind of relevant. He didn't say exactly how much weight because I don't live here. So I don't actually know. I can't see for myself that he's lost like so much weight over how long. But I just know the fall was mainly related to his blood sugar. But I just from school have learned that usually benzodiazepines can cause falls too. And I just figured better be safe than sorry. Was there any other part of your question that I need to answer?
Well, so I think it's kind of a balance between changing a medication that a patient or provider views as helping, right, versus the risks and benefits with their other medical conditions that kind of might emerge. And it really becomes sort of a risk-benefit assessment of the need to change. And that's sort of the point I would enter the conversation with the provider and the patient is you know, you had this fall, and you know, it probably was complicated. And we want to do what we can to minimize the risk of falls going forward, and just wanted to sort of alert you that Xanax is a medication that could increase your risks of falls with age, as well as your needs for anxiety control may have also changed since it's been looked at before, and just wanted to make sure we are looking at that medication as the best fit for you is sort of how I would enter the discussion. I mean, on one hand, it is a very low dose, and the effects on falls and gait do actually kind of over time, people kind of adjust to that. So benzos are more of a problem in the elderly with falls if they come on and off of it, or they use it more PRN. The daily sort of use and compliance probably does decrease the chance of falls, but there are other risks from the Xanax, like cognitive effects and higher risk of delirium confusion that can occur, or withdrawal, although mild because the dose is so low. That, you know, it is really a kind of a risk benefit discussion, and it could have just been that nothing else has been tried, and it could be, you know, how motivated the patient is to make a change. I mean, I would also say if his anxiety has been that controlled for decades and never been reassessed, he may not need any medicine for anxiety anymore. And you know, because we usually think about tapering it off after that much success, and just minimizing sort of all that polypharmacy that has probably added on even since the Xanax. So I think it's entering into a conversation about changing something, right, that the provider and the patient are comfortable with. And how do you do that by using this event in a helpful way? So, I think this is probably the type of thing that I think faxes are interesting, but I don't think they're going to probably, I think I think just if there's a way to kind of have more of a either to the patient or to the provider discussion about, we noticed that you had this event. We just really wanted to take a look and make sure we weren't missing anything, and just had some concerns about, this medicine maybe adding to that risk, or if there might be better options that help, would sort of be my entry point. It could also be one of those things no one's even looked at, because anxiety was controlled. We just didn't even consider it. It was just working. And so I think that is sort of the, how do you get the nugget in there to start a conversation is really kind of where I would start. I don't know if I use a lot of motivational interviewing techniques sometimes in addressing that, and just kind of being open-ended about it, or asking the last time people have looked at medicines to just kind of, or asking the last time that the anxiety was a problem, to kind of get at more of the clinical issues. But yeah, I do think there's lots of options. I mean, especially if he's not been on anything from an anxiety treatment perspective, there are lots of different medication choices. SSRIs, of course, are very reasonable. The ones you picked are fine. If there's additional issues like weight loss, some of the like mirtazapine type medications or Emeron can actually help boost appetite while treating anxiety too. That could be sort of optimized based on different needs. I think the next step, there are lots and lots of choices. But I think it's more, how do you get your foot in the door to have someone revisit what seems to be working when a new event occurs. So right. If anybody has other thoughts.
So I actually was talking, I brought it up during a CMR that I was doing for outcomes. So I did talk to him about it, and we gave him a paper with our recommendations, and just asked for him to bring up the conversation with his doctor the next time he goes in to see if they might want to change it. I just mentioned that it could increase his fall risk a little bit. And then I asked him if he had anxiety for a while, and he said, no, it's effective. I haven't had anxiety while taking this. And I was like, okay. So, I mean, he's never had anxiety while on the medicine. So I mean, like you said, it might just be time for him to come off of it if he's been on it for so long. But we did give the patient the packet, and he said he was visiting the doctor next month, and that he would bring it with him to mention it to the doctor. So even though he might not have read my facts, maybe he has the paperwork there with our recommendation and stuff, and he'll actually give it to the doctor. So we'll see.
That sounds perfect. Really, it really does. I don't know if anybody else has other ideas, but that's a great way to engage the patient. I love it.
I was just going to say, nice catch. It's nice to know that pharmacists are watching, paying attention to these meds, and how maybe something else could be better.
Yeah, thank you for the feedback, Dr. Swagger, Dr. Lillard. Any other comments or feedback, recommendations from the group? And Maya, did you have any other questions, comments about this case that you wanted addressed with everyone?
No, I don't have any questions. I'm sorry, it wasn't very interesting. It's just the only thing I came up with while we were here.
No, don't ever apologize for submitting a case and choosing ECHO as your CARS program project. We really appreciate you. And as you can tell, we all got super excited when a case was submitted, like we did this. So don't apologize. And you're always welcome to come back and present a case for ECHO even after the program's finished. So yeah, big shout out to you.
Yeah, I thought it was a great case, and I think it's something people just don't think about, or we don't talk about enough. In fact, I don't think I can remember us having that discussion about benzos in patients after age 65. And so I love that that we introduced that. It was a great thing.
Yeah, no, that's such a great point, Dr. Swagger. I agree. I think you said it's not an interesting case, Maya, but to us, it is, and it's a great discussion point for all of us. So thank you again. All righty. Well, if there are no further questions or comments about the case, we can transition into the didactic portion. Dr. Swagger, if you prefer advancing your own slides, I can give you that ability to do so. All right. And let me know if you get any tech issues. I have all your materials on my end as well, so just let me know.
You guys see all that?
Yes, we can see the presentation. It looks like, oh yeah, there we go. Perfect.
All right. So this is a collection of just some cases. Some of these you may have seen before. I put together just some more discussion points just about pediatric medications and highlighted some pretty common cases that I just wanted to go through. This goes off the point of how much we love cases. So I just pulled some that I had worked on over the years. And as always, please interrupt, ask questions, or if this makes you think of your own case, please just interrupt and let's add those clinical points, because a lot of times it is the nuance of the other factors going on in a case that makes the best choice. So, all right, now why can't I advance them here? Okay, here we go. All right, so this is an 18-year-old with ADHD, a bit lower IQ, had been doing great on Vyvanse, which is a prodrug version of amphetamine salts, until there became a formulary change with their insurance. They were switched to Adderall XR, which was the new medication was approved, but the patient began to experience some more agitation and started having withdrawal dysphoria, which is a phenomenon at the end of the day when the medication wears off for about 30 minutes. Some people can feel kind of really agitated as the medication wears off, and what to think about in terms of next steps. So, you know, a couple things. The reason Vyvanse and Adderall are actually the same active ingredient. It's an amphetamine product, so it was a good choice to switch from. However, they work rather differently. And if you've ever heard me talk about stimulants before, one of the key things about stimulants is making sure you understand how the product is released or packaged in the little pill, because patients will have unique experiences that some may not be bothered by at all, but you can have a change in how someone's symptoms respond when the pattern is different. And so Vyvanse has to be cleaved by the liver and first pass metabolism to release its product. And so as a result, Vyvanse tends to take a little longer to kick in, and then it tends to have a longer duration of action, almost up to 10 to 12 hours kind of throughout the day. And it has a much slower kind of fall off pattern in terms of the way it's processed. Adderall XR is a combination of dual salts. And so if you take an Adderall XR capsule and you open it up, it has two different color beads. The beads, one color bead releases immediately, and the other color bead sort of comes in later in the day. So when you get an XR Adderall medication, it kind of releases a 50-50 split of those beads. And we'll talk about how that can be different as well. So an Adderall XR dose of 15 is more like getting 7.5 of a short acting, and then the other 7.5 later on. And so it can look a little bit different than the release pattern of that Vyvanse in terms of how someone appreciates it. And it also wears off faster. It doesn't have the slow release. And so that withdrawal dysphoria, the moodiness that comes, that can happen from any stimulant actually. And you can think about treating it. So if it's really this intense 30 minutes of irritability and withdrawal where the ADHD comes back and the mood symptoms hit, sometimes you can correct that by adding a short acting dose. So usually around 4 o'clock, around the 8-hour mark, 6-hour mark, when the XR wears off. And that's a very personal thing. You want to ask, when exactly do you notice it? In an ideal world, you'd take the short acting dose of the Adderall a little before, about 30 minutes before that wear off effects. And then you'll get, again, it's a lower dose of the Adderall, but it will also kind of temper the withdrawal dysphoria and treat the ADHD a little into the evening without that dramatic drop off. So that would be one way to correct it and get a closer release pattern to the Vyvanse. So it lasts a little bit longer, you get a little slower taper off on the kinetic side of how the medicine works. The other option is to think about a different medication. And this is kind of where, you know, there are two types of stimulants. There's amphetamine products and there's methamphetamine products, Ritalin or Adderalls, or depending on how you look at it. But you can change to methylphenidate product. If you look at populations, you know, about 70% of people will respond to any stimulant. And then there's smaller groups that will do better with one or the other. So, you know, while the first choice, switching to the most similar product, might make sense, you could actually try a different product. And so if we think about Vyvanse being that long-acting, slow release, slow taper off, another medicine called Concerta, or it's more of an osmotic oros release of methylphenidate. It kind of pumps it out through the stomach through this osmotic gradient, and it has a sort of slower release, but it too takes a while to kick in and then they're off. And then the medicine dose is actually quite split. So about 22%. So in a 36 milligram dose, about 8 milligrams will come out first. And then the rest of that medicine will be released slower throughout the day. But its length of action is closer to Vyvanse at that 10 to 12 hour mark in terms of a slower release. And so this does highlight a couple things, is knowing how the pill works, how the release pattern happens, and really focusing on the timing of the symptoms, right? So when you have somebody that is being treated with ADHD and you're using stimulants, you really want to think about when are those three key symptoms being treated well, right? So attention, focus, impulse control. When is it treated well? When am I seeing those symptoms return can be really helpful, but also when you hear about a side effect, knowing when the side effect occurs. As a phenomenon that occurs when the medicine wears off. Agitation can also occur from the stimulant when it kicks in. In this case, it was a wear-off effect, meaning the effect was happening when the medicine went out of the system, whereas some people might report agitation when the medicine kicks in as it enters. That's a whole different response. And so withdrawal dysphoria can be treated with another dose. Whereas if you're getting agitated from the stimulant itself, you probably need to change the medication. So there's different ways to think about how you balance side effects and treatment. The other sort of learning points from this case is just how often formularies change. They change often, and sometimes it is keeping up with what is cheapest for the patient. And sometimes you have to change medication often because people can't afford the medicine they were on. And so you do have to keep up with that and be aware. And it's also a time when people stop their medicines or symptoms come back. So whenever people aren't doing well, asking if they're taking their medicine, making sure they're not skipping doses can also be a part of that. And so what I would say is you want to stay abreast of those things, especially if you can. There are easy ways to do that. If it's Medicaid or a PEIA, they tend to use a static formulary that gets a lot of people. Each individual insurance, if you get their insurance card, can usually pull the formulary up online to quickly look at it and see might be available. Right now, we're still having medication shortages of stimulants. So a lot of kids are having to change their stimulants because of production issues and not being able to get medicine. And so it's really important to kind of stay abreast of the calculations. And as a general rule, about 5 milligrams of IR Adderall equals about 10 milligrams of a methylphenidate IR. But when you get into the long-acting products, those conversion rates can be a little bit off. So you want to make sure that you are checking those and double checking those. Checking with pharmacists are always good. Usually when formularies change, they do also put out a release of things with equivalent conversions for people that need to change. You can check. And hopefully here at the end of June, the Rational Drug Therapy, and I admit I'm included on that panel, is releasing a big guideline for ADHD medications that will include several tablets on calculated conversions that are really helpful. Again, we talked about how important it is to understand timing, not only the timing of their symptoms, but really understanding how the medicine releases, because like in that example of the Concerta that I gave you, where 22% releases early and 78% releases long, the patient comes back to do, they're doing great in the afternoon, but they're really still struggling for the first 2 to 3 hours of the day. That may be because the release pattern is different, not because the medicine dose is ineffective. And so you have to be mindful, if you would increase the dose, to realize you may not be putting that medicine in the afternoon when you increase the dose, because the problem's in the morning, and that's not how that medication releases. So these little nuances can really help you become a better clinician in terms of targeting what dose is needed when, and making sure that dose is consistent as possible throughout the need. And so that was case 1. Any questions or thoughts about stimulants before I jump into the next one?
I'll keep an eye out for the chat for you, Dr. Swagger.
So there is a question. Does the availability of current ADHD products impact the decision? Oh, absolutely. You are probably seeing this, I'm sure. I've had some kids have to switch medicine literally every month in some of the shortage periods because they can't get their medicine. And I have called pharmacies and said, just tell me what you have, and I will try to convert it to cover their needs. And that's not perfect. I mean, kids don't do well with med changes. I would also add that as kids grow, there's med changes and needs that happen anyway. But it has really been a very challenging couple of years with production supplies with this, because there are people that have called tons of pharmacies, and I'm sure it's hitting rural America far worse in many ways. This is layered on with the fact that a lot of smaller pharmacies don't even like to have controlled medications on site because they're afraid of theft and crime and all sorts of things. So yes, it has been very challenging. So that's a great question. All right. Okay, the next one. Unfortunately, this is a very, very, very common thing. And I'm gonna have to exit this to share something with you here in a minute, but I'll include it. So this is a 16-year-old female. This one I actually got through a pediatrician, where the pediatrician was calling sort of proactively because they had a 16-year-old whose mom was been caught vaping, and the mom was really, really worried about the extent of the vaping, and thought the child had become addicted to the vaping. I think she may have even gotten in trouble at school or caught vaping at school. And it kind of came in as a question from a pediatrician. Well, how would I treat a teenager essentially that has a vaping addiction and nicotine use? And can I even use medications, or what are your thoughts about this? And this, if you are not savvy, this is really becoming an epidemic of sorts in schools. Kids are using vape all the time. It's kind of like smokeless was before. It's a lot more secretive. It's harder to smell. It's harder to see. People are doing it in the bathrooms. High schools now have vape detectors, but I've had kids puffing it into the locker at break, down their shirts. I mean, it is quite problematic. And so you got to start by really kind of engaging the kid. We talk about using a lot of motivational interviewing. You have to understand how much they're using. You have to understand why they're using. A lot of times this doesn't start as a desire to be addicted to vape and nicotine. And a lot of kids are doing it for things like paying attention or focusing or trying to control their appetite or hang with friends. And you have to be mindful not only about how much they're using, but also to understand the reasons they're using, because for a lot of kids, they do become highly addicted, and it's hard for them to imagine stopping because they like some of the benefits of it. And so you really want to have a full discussion with them. When you're talking about moving toward treatment, this is a frame shift for a lot of people. You really need to understand the milligrams of nicotine that are being consumed to think about treatment with, especially with the nicotine replacement therapies. And I'm going to talk about how to do that here in a minute with vape. There actually is a validated instrument now called the Penn State e-cigarette questionnaire that can help you gauge how heavily addicted someone is in terms of their nicotine use, whether it's a low, moderate, or high level of addiction. And that can also help you decide on how to treat that. So that is something we could give this child. We want to ask for if they're using daily. We want to note what happens when they can't use their product. You know, are they sneaking their product? Do they report withdrawal symptoms that they're having? A teenager that's using daily, that can't make it through a school day without using and reporting marked withdrawal, is probably getting up there into moderate and high levels of addiction at this point. And most of the pediatric providers and the child and adolescent psychiatrists, like big national studies, are saying kids are not able to quit vaping without help and support. Their level of addiction has gotten so high and so much faster than we've seen with just traditional cigarettes. The vape itself has been chemically manipulated with salts and pH changes to make it more tolerable. So if you ever smoked a cigarette, you probably coughed the first time that you did it, or it burned your throat and you had some type of aversive reaction. Vape has been manipulated to get rid of the burn, and some of them have had flavors and things added to make them, frankly, enjoyable while getting a ton more nicotine. So this is not as aversive as what many people and their products have felt before. And it tends to not have some of the negative smells and ability to be caught or be negative as some of the other products have been. So so basically, if well, let me show you this scale first. Let me stop this share, and I gotta find the escape. Sorry if I lose it here. Let me show you this nicotine for the Penn State questionnaire. Let me try this again. Oop, lost my share button. Hold on. Sorry. Okay, can you see this now?
Yes, we can see that.
So I'm going to talk to you a little bit about how to calculate those milligrams of nicotine that you need to calculate to do nicotine replacement therapy. But this is free. You can get this online. This could be good for adults and kids. It is specifically for, oh goodness, this isn't the E one. I'm sorry, I pulled up the wrong one. Hold on a minute. Sorry about that. Well, I have failed completely. I will make sure you have the electronic one.
I can try to share on my end if you'd like. Let's see if is it one of the ones you sent me, either this or this one?
I have sent you the wrong one.
Oh, that's okay.
So anyway, there is a specific one that you can give for people using e-cigarettes. There's also one for cigarettes, and just to be cautious about time, I'll make sure you get the correct one in the mail out. But what you can do is with these questionnaires, and it may be the link here, there's also one for smokeless. There's also one for just traditional cigarettes. You can use any of these. It will give you a rating if they have very low, moderate, or high levels of nicotine, and then recommend medications as a result of this. This kiddo, when she filled out the e-cigarette use, was using about a pod of, at the time it was a joule pod a day, was using a joule pod a day, was having problems stopping use. With that Penn State scale, had really come back at kind of a moderate level of addiction. And so this plan right here was for adults. In children and adolescents, the guidelines for treatment are different. Briefly, let me shift back now to this PowerPoint. I'm sorry, I'm not savvy with my, whoop. Try this again. Okay. Back to PowerPoint, you can see that, correct?
Yes, we can see that.
Okay, so she was using daily, really at the amount she was using around 25, more than 25 milligrams of nicotine a day. And I'm going to compare that for you so that you understand how much that truly is. But this level of use at over 25 milligrams a day really is a level of use that is very hard to just stop. It reflects a level of physiological dependence and severe craving that really might suggest that nicotine replacement is warranted. And so for adolescents, the best treatment is a patch plus or minus a nicotine ad lib, which is either adding on the gum or the lozenge as well. And so based on her use, I would have given her about 21 milligram patch, 14 to 21 milligram patch, as well as choosing a 25 milligram gum or 2 milligram gum or lozenge to use every 1 to 2 hours while she's at school, as needed for those emergency cravings. The idea is to get the daytime control in that patch, but the patch takes about 8 hours to kick in. It has to be used daily, but kids will still have breakthrough cravings. And so I would allow them. I prefer the lozenge myself because the gum actually requires that you chomp it and hold it in your cheek as opposed to chewing it like chewing gum. And I feel like a lot of kids have trouble with that. They also tend to get in trouble for having gum in school more often than lozenges, where the lozenge you just tuck into your cheek and it absorbs. But if you do that with a child at school, you have to get parental permission. You have to fill out this form so the nurses allow the kids to have it. I've never had a school not allow a child to have their product, but I've had children try not to let the school know and get in trouble for carrying it on them. So I really highly do suggest that a med form be filled out with that. You actually can get coverage. Some of the insurance plans will cover it for adults. I don't honestly know about commercial insurance and kids. I know the health plan and PEIA have their own private programs for tobacco use. I've not accessed those for adolescents, so I can't tell you the specific details, but you can, with Medicaid or no insurance, get product for kids. You have to go through a little specialized process because there has to be an additional signature either of the parent or the provider that the child's in care. An adult can just call and get product sent to them and enroll, but you have to do a little extra statement if you're a kid because they won't just mail the product to the kid. But you can call the 1-800-QUIT-NOW line as a child with their parents or the provider. And I've had to sign forms as a provider that I'm prescribing it. And the parent has to give permission, but if they do that, they can still get product through the QUIT line mailed to their home and still get access to that. It does require some extra steps than adults, but it is still an option. Also, the patch and the gum lozenge are also available over the counter, and I've had many parents just go purchase those. It is helpful to dose it correctly. A lot of times the mistake is that people get underdosed, and I'm going to show you why. And if they're underdosed, the kids will just keep using their device just to get more nicotine. And so it is important to try to match that. It's also important to follow up closely so that if you want to recheck in a week or two how somebody's doing, because if they're using a ton of as needed, you may have to adjust the patch. If they feel a little nauseous, you might have to drop it. It can be something that needs corrected kind of quickly. There is some studies also with bupropion or Wellbutrin in teens, so it is reasonable to do that. The formulation that's been best studied is the SR version, and the dose is the same for adults. It's 150 milligrams for 3 days, then 150 milligrams twice a day. I think the bupropion is sometimes a good option in people that are worried or have comorbid depression or other issues with addiction. It works by working on dopamine to help with cravings and has a mild stimulant replacement effect as well. Chantix or varenicline, which is often used in adults and one of the top medications in adults to use in terms of efficacy, just does not have enough studies in kids to make it used. So we really do tend to stick mostly to nicotine replacement options. I'm not sure they were great studies. I'm not sure they went out far enough, but there are some negative studies. There's some safety studies, like it doesn't appear to be dangerous or have significant side effects, but there's just not enough efficacy that it works to really suggest this at this point for teens. So about 20 to 30% of high school students really are reporting enough use of vape that they may need replacement treatment. These numbers are increasing and huge. Many things are suggesting we need to support kids. It's also important to ask kids specifically about vape. A lot of pediatricians who used to screen kids for tobacco, they don't even recognize vape as being related to tobacco, even though nicotine is still the addictive agent. It does not have tobacco in it. So it's actually important that you ask, do you vape or use electronic devices, and not even assume that the child or adolescent includes it with smoking. Many adolescents do not know they're even related. And so it is important that we look at it as a separate and ask about it separately. And then this is that milligram understanding. A traditional cigarette had about 1 milligram of nicotine in it. A pack of cigarettes, so 20 milligrams. And if you remember, I said 25 indicates a higher level. So a lot of kids have more than a pack a day habit. If you want to go back to old language, a cigar has 20 milligrams, hookahs have 20 milligrams. And I'm going to blow your mind with this next slide. But these are just some products. They're new products every day. I think they're like over 100 different devices. These are probably a little old. Juul has gotten itself sued that it is kind of left the market, being replaced with puff bars and Sorens and new products every day. But when you look at the amount that are in the pods, you start seeing ridiculous amounts of product. And so I do have kids using a puff bar a day. That's like 50 milligrams a day, right? And they do extract it differently, and every device is a bit different. You can go look up the device, but it is kind of hard sometimes to calculate the exact milligrams. And these are standardized 4th generation products where they're packaged, but people are mixing. They have mods and they'll mix their own syrups and add their own solutions. When people are using those types of devices, it is very, very, very hard to calculate the milligrams. So I really like using that Penn State e-cigarette questionnaire to find out how many pods they're using and their level of withdrawal, because I will start my treatment based on that other algorithm sheet I showed you. Like if it's moderate, I will start at around 20 milligrams. If they're very high, I might even go higher, because it is a hard conversion to make, especially if they're not using one product. And what happens is a lot of kids will start using mixed products. They will start then getting traditional cigarettes or using different devices to get their nicotine. So it becomes very hard to just calculate straight milligrams. I think this is the correct link, but I don't know that it was correct in what I sent you. So I will make sure before you send it out, I will make sure I have the correct one to send out. So any questions about nicotine replacement case?
I had no idea those vaping numbers and the amount of cigarettes per vaping. I had a parent come in recently and she talked about her son got in trouble because he had a dirty urine screen for marijuana, and he claimed he wasn't using marijuana. All he had done was use the vape pen in the bathrooms at school. And so then at home, she tested all the kids' friends and the younger sister, and they all came up positive for marijuana. And they're like, we're not smoking marijuana. And she's like, you don't realize that's what's in this pen. And so I was kind of surprised when she was telling me that these kids could be even using marijuana and not realizing it.
Right. And if they're using the devices that you can manipulate and add your own things, you can add all kinds of things. I mean, you can try to use other substances as well. So yes, that is a very strong point. You put this in the chat. This is the correct link. that asks how often are you using it? The question about how soon do you need it when you wake up? If you use your device within 30 minutes of waking up, or people that wake up in the middle of the night to use their devices because they're withdrawal in the middle of the night, that really puts them into that very high level of addiction. And so you can give someone this questionnaire and then use this low, medium, or high level of dependence, and then that algorithm that I sent to really kind of figure out where you're going to start with nicotine replacement therapy. Again, the key with that is to try to make sure you understand that you have met the person's needs. I am not going to start this case because it is quite long. Actually, this one is the longest case I have. I'm going to actually just pause there. I could probably finish. I have 4 more cases. I probably do this another session and go through them more in details, but let me just pause there. Do you guys like this? Is this a helpful thing to do, is just throw out some cases? I love cases, so this is my attempt. Although Mia, you made me much happier today than my own cases. So
I think it's a great idea. Next time is actually TBD right now. So we could honestly do the rest of the cases and do like an open discussion. I think that's a great idea. And I'm right there with you, Dr. Swagger. I love cases. So that's my 2 cents.
I would just like to mention the other thing that I sent in the group chat is what they give us at pharmacy school to help guide us with our therapy recommendations. I'm not sure if you can open it. I sent it as a PDF. I'm not sure if anyone can open it or not, but it's in the chat and it's our guidelines that we use for our recommendations. I'd also just like to throw a tidbit out there that we recently learned that pharmacists can now prescribe Chantix and Wellbutrin to people that come in. They would just have to do a CE credit. So I'm not saying all pharmacists can do it, but they would have to be certified to do it. So you could also use pharmacists in that way because we can prescribe those things.
Yeah, I can open it. It's very complete. I'm just trying to take a quick look. I think the pharmacists have to go through the certified tobacco training course to get access to that, because we had a lot come through in May. I want to make sure. So one of the things that's especially important about West Virginia, and I'm not sure who this is from, because I think they cut the patch off at 21 milligrams, but there are a lot of people in West Virginia that are really exceeding that 25 milligram mark. So they're in the high dependence risk. And I just want to make sure, I'm not sure it's on there, and it may be, but if you're going to use nicotine replacement in those folks, there are needs sometimes for people to have 2 patches and go beyond the 21 milligrams, because the number one reason sometimes that the patch fails is that it has not been dosed appropriately, and we have one of the highest dependence rates in West Virginia. And so don't stop at 21 milligrams if their use is far exceeding that. And I don't know, I just saw the 21 on there. And that's one of the things that the certified tobacco treatment course really pushes, is making sure that you're matching the need. It is not uncommon sometimes that people need 2 21 milligram patches in a lot of our population. So yeah, but those are great things to share. Thank you so much.
Well, I was just gonna mention, at least for like this upcoming few pharmacy classes that will be graduating, they did make us go through the training course while we were in school. So next few years of young pharmacists will be certified to do it.
Thank you all so much. Any other comments, questions? And yes, thank you, Maya, for those really great resources. I'll also include those in the recap email as well. Any final comments, questions from the group? Alrighty, well, thank you, Maya, again for the case. We so appreciate you. And thank you, Dr. Swagger, for those really awesome cases as well. And we can continue those next time. If you're available next time as well, we can touch base via email, but that's an open session. So we can do sort of like the remainder of that in an open discussion, which would be really nice. So thank you all. And thanks, Amanda. She chatted in saying it was a great discussion. I totally second that as well. But yeah, that's my announcement is that next session is on June 21st, and we'll just continue this great conversation next time. Thank you all so much. And if there are any questions, you can always reach out to me via email, and I'll make sure to have all those questions addressed. Thanks, everyone. Take care.